I've opened the room. Right now, we're going live.
Okay. Ladies and gentlemen, colleagues and friends, wherever you are in the Asia-Pacific region, but of course around the world, welcome to this UICC virtual dialogue on an important topic, supportive care and survivorship for people after cancer, person-centered rather than a disease-centered approach. And what an important topic it is. Jeff Dunn is my name. It is my great privilege to serve as the president of the Union for International Cancer Control, and to me today is full the honour, the particular honour of facilitating this session. And what we might begin with is just a few slides, and then we've got a distinguished and esteemed panel of commentators, professionals, clinicians to talk with us about this very topic, supportive and survivorship care. You might have heard at the beginning, just by way of warning, we are recording the session. So if you are interested in notes or catching up with some of these slides later on, they will be available. We are recording and we will post this on the UICC website. As you can see from the current slide, and I think everyone on this call will know that every year there are more and more people being diagnosed with cancer. You know, globally, cancer incidence is growing. There were just under 20 million new cases in 2020, up from 14 million in 2012. And projections out to 2030, you know, speak to 30 million people being diagnosed with cancer. The numbers of people getting diagnosed with cancer is increasing. Next slide, please, Alessandra. And the number of cancer survivors is rising worldwide. So there is some good news in there. While there are more people getting the disease, we're happy to see an increase in those who are actually surviving. In 2018, there's an estimated 44 million, let's say, cancer survivors diagnosed within the last 5 years. And this is up significantly on what we're expecting. And in some countries around the world, 5-year survival rates for some cancers is just under 100% now. Unhappily, that's not the case worldwide, and we need to make sure that we look at addressing gaps in equity and outcome. But in general terms, you know, survival rates are on the increase as well, which means, of course, that there are more survivors out there. Next slide, please, Alessandro. So what we're talking about today is about supportive care and survivorship and different ways that that might be interpreted, understood, and then deployed in countries and communities around the globe. And of course, it can be of benefit to patients in different ways. It can be about alleviation of symptoms and complication, prevention and reduction of treatment toxicity, improved communication with caregivers about disease and prognosis. And you know, there are some cancers where the research tells us that from a psychosocial point of view, the actual caregivers do less well than their loved one with cancer. So I think we must always remember caregivers, increased tolerance and thus benefits of active therapy, ensuring people stay compliant with those therapies, easing emotional burden, and psychosocial support for cancer patients. All of these things may well be part of that supportive care, that survivorship framework, a fabric that can make a difference in the lives of people diagnosed and treated for cancer, and of course, the people that care about them. Next slide, please, Alessandro. There are different ways to look at, you know, the patient experience of cancer. This is one model. If we look at the left from Margaret Fitch in Canada, and you'll see there are a series of domains: psychological, physical, social, spiritual, practical, informational, emotional, and each of those are important areas. You know, I think we need to understand that survivorship or supportive care is not one thing. There are different domains, different themes, different areas which might be more important for people at different times in that continuum, because it's not a set point in time, and it's not the same throughout that, you know, that trajectory from diagnosis through to treatment, through to survivorship. And then there's another categorization of needs there on the right, which was by Webb and others, about the biological work, the everyday life, and illness-related work. So the things we need to focus on at any particular time as a cancer survivor. I suppose we show these just to make sure that we point out there are different ways to look at supportive care and that survivorship experience. There's no one particular right way. And of course, in the end, it's up to individual patients, to manage their experience with those around them, their loved ones, their families, their healthcare team, their clinicians, their friends and their communities about survivorship and that experience. May we have the next slide, Alessandro? So we have a terrific agenda today. And as I said, we have got some quality people to help us make our way through this next hour. So we'll spend a bit of time on the patient's perspective. And you can see that we're taking an in-conversation approach today. So after my slides here, not too many, it's more about a discussion. It's more about getting that depth, that feeling from individuals who are either cancer patients themselves or who work very closely with them in relation to supportive care and survivorship. So we'll spend a bit of time getting the patient's perspective. And then we have a panel of service providers. And what an experience we've got here, from Morocco, Rwanda, and Singapore, and looking at different ways service providers and organizations can try and meet these needs. And then we'll finish with the discussion about health systems with an expert in that area who has done some research, particularly in a regional perspective. In this case, it's that Indo-Pacific region, and just looking at what lessons Bogda Kozwara has learned as a result of that research. Next slide, please, Alessandro. So we will begin with the patient's perspective, which is in conversation with Chris Cheng. And I think maybe why don't we work through the slides, Alessandro, so we can show people who's coming. After Chris and I have a chat, next slide, we will then have a panel discussion with Diane Ndoli, a clinical oncologist from Rwanda, with Majda, who we hope is with us. She's been having some technical issues, but we're hoping she will be able to join us, from civil society in Morocco, and Mark Lin, who's the head of the psychosocial services department at the Singapore Cancer Society. And we'll have a panel discussion, and then we will move on to an in-conversation with Professor Bogda Kozwara, who's an Australian like myself. She lives in a different part of the country, but it's always good to catch up with Bogda. And Bogda and I will just be talking about, what she's learned from her research globally and here in Australia about supportive care and health systems. So that's our program. Next slide, please. We're live. That's the slide. We were trying to make sure we limited that as much as possible because we want to get on to the good stuff. So our first session today is with Mr. Chris Cheng. Now, Chris, where's Chris? There he is. Chris he's from Malaysia. Hey, Chris, you hail from Malaysia, one of the most multicultural societies on the planet. So we might touch on that on the way through. And you're talking to us as a founding member of SCAN, the Society for Cancer Advocacy and Cancer Advocacy and Awareness. So terrific. First of all, welcome. Thank you for being a part of this.
Thank you for having me, Jeff.
It's a pleasure. Chris, let's jump straight in. As a cancer survivor yourself, someone who's been diagnosed and treated for cancer, tell us a little bit about your experience.
When I was diagnosed with cancer, I basically, have no much interaction with the healthcare system. So even going to the hospital was like, where do I go? Who do I see? It was all very difficult. There was no patient navigators that time. So this was what, 10 years ago. So you basically had to, the nurses wasn't free to guide you around. We didn't have that type of resources. So you basically had to go and find things yourself. You say, go do blood work. You have to find your way to the lab, which might be 2 or 3 blocks away. So that was always kind of a difficult and challenging time. I myself, I got cancer when I was my late 30s. So it's a bit easier, you know. I'm educated, I can speak multiple languages, so language wasn't that much of a barrier. But if you were to meet some of the other patients, patients we have in our hospitals tend to be from the rural areas, especially in the hospital here in our state. So they are not that educated. So sometimes they will feel overwhelmed, as you would be. You know, you just had this diagnosis, the doctor just told you, oh, you have cancer, and now you have to navigate your way through the whole system kind of blind. So obviously, during that part, the supportive care is really very important. But as you go through, during the whole treatment itself, then it starts to change the needs that a patient may want. Like for myself, I wanted to know more about my treatments, but where can I get that information? Of course, we are lucky living in the world of the internet now, where you can actually get supportive support from other people on that. I actually found a Facebook group for Hodgkin's lymphoma, which is what I had. And for advanced Hodgkin's lymphoma, because I was refractory, so my treatments didn't work. So I had a group of people from around the world to help me, but that's not true for, you know, a lot of people out there, a lot of patients. So supportive care then it's important. And then even after the treatment, you still need some help. You try, if I'm still of working age, so it's a challenge to get back to that old routine of going of working. Even though I run my own business and I had good business partners which allowed me to take my time with work while I was undergoing treatment. But when you get back, you still need to ramp yourself up. It's a totally different feeling. I'm not sure whether I'm saying it correctly, but it is a challenge to get back to work.
Yeah.
And work is, the ability to work has been shown to be a good marker for quality of life. People do want to get back to work, but it might not be so easy. And I myself, as a business owner, I'm quite lucky, but there are other patients out there that might not be able to get back to work because they're too fatigued. They're fatigued all the time. They might have some blue collar job, which makes it even worse. You know, or I've even heard cases where white collar workers get released because they're getting a bit old, and the company says, we don't want you anymore. You're a cancer patient. You might need more treatment later on. Yeah? And they get fired. So
there's discrimination as a possibility too, isn't there?
Yeah, there is.
Yeah. Chris, tell us, in Malaysia, I mean, there are three, which we have discussed in different circumstances. There are three, you know, distinct groups in a sense, ethnic. I mean, there's the Malays, you know, the people with the Indian background and Chinese background. Are there differences in the way? I mean, have you noticed differences in the way, you know, survivorship and supportive care presents? And is it, do they approach it in you know, are different things important, or?
Yes, there are some differences. For example, there's still a bit of a taboo going on in our area. So some people are not comfortable telling people that they have cancer, so they lose out on support that way. If you're not going to tell anyone, you know, who's going to give you a hand? Who's going to help you? So you just hide in your own room, in your own corner, hidden away. Now, sometimes that leads to a default in their treatment, because they just can't take it anymore. There's no support for them. So I live in Sarawak, which has 30 over races, not just the Malay, Chinese, and Indians. We have a lot more races, and yeah, you're right. It can be different based on ethnicity, especially those that are more towards the urban side. They get their support differently. Those that are in the villages, they might have a stronger community bond. So that helps.
Yeah, it does. Tell me, in Malaysia and the scan, you know, the work of scan. I mean, what types of things are you doing in your country, in your state, in your region to try and raise the profile and the importance of supportive care and survivorship?
Well, we actually do have a patient support program out there. We do peer counseling. So we have cancer survivors manning for, our phone lines, Tuesday to Fridays, 2 to 5 p.m. So anyone that's that needs help, they can contact us through that number or WhatsApp through that number as well. So we do get once a few patients, especially those that have been recently diagnosed. They will contact us. We try to help them along their journey. Then we have survivor sharing sessions as well. So cancer survivors, previous cancer survivors can share what they went through and try to pass on that knowledge to the newer patients. So actually, I had one on Monday, and we were actually going through discussing on how exercise can help during and after treatment. So yeah, I did share that after I did have stem cell transplants. So after my stem cell transplants, I was very weak. I told them I couldn't even get out of bed easily. I had to get on all fours and slowly climb myself back. But after a while, you get back your strength, things like that. So it helps. It helps those newer patients to have hope that things can get better.
Well, you're right. There's a lot of evidence about the benefits of exercise. So that's terrific advice you're giving. Are there any themes, like when people call into your helpline, are there particular things they're calling about, Chris? What are you hearing most about?
You know what's the most? Diet.
Diet.
Diet. What can they eat? What can't they eat?
Yeah.
Yeah. So that's like number one. Yeah. Because people here, they have a lot of taboos on food. So there are people, their friends telling them you should not eat meat, you should not eat carbs, you should not eat sugar. But we always tell them, do it in moderation. I think there's nothing that's
Malaysia. Sorry, go ahead.
There's nothing that the doctor said you can't really eat unless you're on some sort of medication that contraindicates on certain type of foods. So that's what we tell them. Tell them, if I've even had doctors tell me, if the patient really wants to eat KFC, you should let them eat KFC. The treatment time is when they need that type of energy, that type of nutrition. So you worry about nutrition, what harmful foods they are after the treatment.
Yeah. I do know, and I have heard that in Malaysia, in relation to treatment, that some of the traditional healers, can cause some, from an informational point of view, some challenges. Do you find that that's also the case with supportive care activities, about the sorts of things that people might do after they've been treated?
Yeah, there are still alternatives out there. People tend to believe in alternative treatments during, even after, but after they get treated and they're okay already, we tend to be a bit better about that, because as long as it doesn't hurt their health, it should be okay. But it's during the treatment that we tend to tell them not to just do their treatments first before going into those alternative stuff. But some people do do get positive benefits out of spiritual healing and things like that, which is quite common here as well. So
Yeah.
as long as it doesn't hurt their treatment, I guess it's okay.
Exactly. Chris, we're going to have to wind up soon, but before we do, one last question. You know, if you had a single message, for health providers and clinicians out there about supportive care and survivorship that you wanted to get across, what would that message be?
For healthcare professionals, I think they should see patients as human beings and not just another case, not just another number. And how you would treat your mother or your father or your sons or daughters, that's how you should be treating your patient. If if it's your own parents, you would try to support them all the way. They're not just another case, not just another statistic. You should try at least to connect them to NGOs or other social workers to help them through this journey, which is, I'm sure you know, Jeff, it's not an easy one.
Yeah, exactly. Chris, look, thank you for that. We're going to have to sort of wind up our part of that conversation. And just to let you know, you and I, we didn't get a chance to talk about this before. We're bound by other things. I too have been diagnosed and treated for lymphoma, a different variety. But one of these days we'll sit down and have a chat and talk about
yes, we should. Yes, we should.
our relative experiences. I think, as you can see from my head, I've been treated much more recently than you, but we can talk about that later. So, Chris, can I say thank you to all of you out there? Maybe if you use your gizmos, and we'll give Chris a round of applause, don't you reckon? I'm sure there's clapping hands in there. Hey, listen, Chris, thank you for joining us today. And if we've got time later on, we'll take some more questions. And also, congratulations on the work of SCAN, hey? Well done. Okay. Ladies and gentlemen, we might move to the next phase of our session this evening. And a reminder that we will be recording this session. Well, we are recording it. Alessandro is sitting in our UACC Geneva office, happily recording there. So it will be available later. And of course, if you have questions or queries, drop them in the chat box. And Alessandro, again, will be looking through those. And if we have time, we will certainly be coming to those as we go through the session. Nice to see so many of you out there, I must say. So now we're moving to the next part of our program, which is a panel discussion with three, service providers. I'm hoping three, it might be two, but I'll check in with Alessandro in a minute, just about survivorship and survivorship care and how we might work with that. And I'm taking it from seeing Diane and Mark up there, Alessandro, that Majda has not been able to join us.
Just checking in. Maybe we can call on air and just check in. Is Majda, were you able to join us? I'm just checking on the list of participants.
Yes, I'm here, but it seems that I have a camera problem issue.
But we can hear you well, so
Okay.
hopefully that will be enough.
I'm sorry.
Majda, please, you no need to apologize for technical problems. I have them half a dozen times a day. It's just quite lucky this managed to work this afternoon. So, Majda, can I thank you for joining us? So we have Diane, who's a clinical oncologist from Rwanda, and she's joined us here. So thank you for that. We have Majda, a civil society organization in Morocco, who's joined us. We can't see her, but we can hear her. And we have Mark Lin, who's head of the psychosocial department at the Singapore Cancer Society, and Mark is a social worker by trade. So we've got three distinguished panelists, which is terrific. What I might do, just briefly to start with, is maybe just check in with each of our panelists briefly on, supportive care and survivorship in your respective countries. Can you just tell us a bit about it? Diane, what's happening, in Rwanda with regard to supportive care and survivorship?
Thank you very much. Jeff, and thank you for this important topic. I must say that in Rwanda, we still have a huge gap in supportive care and survivorship. I would say that more emphasis has been made on, the awareness of disease, early detection and treatment. But this has been mismatched with, supportive care and survivorship. So we really have a big gap in that area, if I must say, yeah.
All right. Well, look, thank you for that. Majda, how about in Morocco?
50,000 new converts.
Thank you first for the topic. And if I can just introduce briefly what we are doing and what we are providing in our organization. And we offer a completed supportive care program to cancer patients, covering 4 areas: psychological support, adapted sport therapy, individual well-being sessions, information and advices workshop in nutrition, natural therapy, dermoaesthetic, etc. And the purpose, we are the only organization that we offer this coordinated program of supportive care in Morocco. And the fact is, the purpose is to help cancer patients to improve their quality of life and to feel more involved and having more control on their disease. And in Morocco, promoting the supportive care is one of the objectives of the national plan for the cancer control. The plan highlights the importance of the supportive care, but it's not really a priority, because currently we are focused on in the national level on the medical coverage.
Yes. Hey, Majda, thank you for that. And thank you for telling us a bit about your work. I mean, it sounds terrific, and we'll come back to some of those points you've raised. Why don't we now just flip over from Morocco to Singapore? Let's just take a bit of a dash across the ocean to Mark. Mark, tell us about what's going on in Singapore from a supportive care survivorship perspective.
Right. So for Singapore, we actually have a cancer rehab center, of which, just now you were showing a chart with all that important things that's about the practical, the financial, social, the spiritual and all that. So the philosophy of the cancer rehab center basically creates that kind of program. So we want to have a cancer rehab center that looks into all the aspects. So in 2015, when we started the center, it wasn't funded by the government. So the charity had to, really use charity dollars to fund this. And then, the good news is that, years down the road, 5 years down the road, actually right now we are recognized as one of the programs that can be subvented by the government. So it's a great deal, right? So I think the key thing is that how do you bring cancer rehab as part of mainstream service? So some of the challenges that Chris mentioned about navigation, about how do I find support, mental health, and all that, right? So the way we see the issue is that because you haven't integrate supportive care as part of mainstream service. So this is the biggest problem, right? So traditionally in the hospital level, they are primarily dealing with infection control and all that. So cancer is not. It's NCD, right? So it's a lifestyle issue, it's a bit genetic. So it's not so straightforward. So if you really want to have, some way of putting the mainstream service, it does require some changes to your system locally and at the government level. So that's where we are right now.
Tell me, Mark, just from a cultural perspective, people in Singapore, the individuals, the patients, the families, is supportive care, is survivorship a concept that's well understood? Do people seek out that sort of help, or is it a case of being much more stoic and just trying to, deal with things themselves? I mean, is there a job to be done in not just educating the governments and the health professionals, but perhaps also individual cancer patients?
Okay, so I need to qualify first. So Singapore is unique in the sense where, number one, we are very small. We only have possibly about 5 million population, of which local population is about maybe 3 million-ish, something like that. So very, very small. Second point is Singapore is like a city state in the sense that I don't have a, like rural area or like a countryside thing. So everywhere is in a city. So if you look at a profile like that, what it means is that in terms of accessibility for treatment, and all that, it's easier in a sense, right? So there's some benefit in having a geographical structure that works in this way. So and because we also need to recognize that there are many different efforts within the country that supports other things. So for example, you might have volunteers to visit older adults, right? At the same time, maybe this older adult happen to have cancer, correct? So then after that, then you know that, oh, okay, somebody's reaching out to the person. It's just that this person is not under the society's purview, right? So in terms of outreach, there are many elements of the society is doing many things. So we don't really get as much issue pertaining to that. But I think the increasingly there are some new challenges because of aging population, and then the way that we structured the living condition, which is you live in flats most of the time, which means that now you have people maybe dying at home because you don't have a caregiver or something like that. So I think this is right now another kind of problems that we are actually dealing with. Yeah.
All right. Look, thanks for that, Mark. I'm wondering, Diane, in Rwanda, I mean, what's your experience there? I mean, from I suppose, an acceptance point of view, a cultural point of view, when a cancer diagnosis is made, what's the experience for cancer patients?
Yeah, so thank you, Jeff, for that question. For my cultural point of view, I would say there's still kind of taboo talk about some of these issues related to supportive care. But surprisingly, for example, in my everyday clinic, I realized that most of the concerns that I get from patients are more of their supportive care needs. So the question comes, is this just a perception that maybe there are cultural issues that maybe lead to them not speak out of their problem, or we really don't reach out to them and understand their needs? So yeah, I think they have a lot of issues on their supportive care needs, and they're yearning and calling out for help, that we really need to go and look into that.
And Diane, can I just ask a follow-up question? Majda tells us that in Morocco, supportive care, survivorship care, improving quality of life as part of a national cancer control plan. Do you have any such, political support, government support for supportive care in Rwanda?
No, not really. So in pipeline, we have more of like palliative care in action plan, but that is not really active. But supportive care, it's not seen anywhere. And I think that gives us as clinicians or other, organization the job to really show these policymakers the issue and the need of supportive care.
Well, here. Well, and good luck with that. Majda, if I could come back to you, you mentioned you have a service in place which deals with 4 domains and does a terrific job. Can you tell us, what were the barriers that you faced? What were the challenges in trying to set up a service like this in Morocco?
The challenge is to make the oncologist more to be prescriber of supportive care, because actually they all aware and convinced about the importance of supportive care, but they they just forget to prescribe supportive care because they are too busy with treating the disease itself. And that's why we develop initiatives to have a direct contact with the patient. like visiting clinics, hospitals, launching awareness campaign, sharing testimonies of our patients, etc.
Okay, thank you, Majda, and that makes all good sense. Can I check with Mark? Does the Singapore government have a national cancer control plan which includes supportive care or survivorship?
I think right now there's a national cancer plan, and they are trying to look into all the varying things, including like palliative care. So, but I think right now the government is concern is more of drug costs, because I think, like I mentioned to you, in terms of Singapore population, we're quite small. So in the sense when pharma companies, when they sell drugs to Singapore, it's quite expensive, and because we don't have the population to have a certain market size. So I think this is where the government is trying to fight a battle to manage the cost of drugs. I mean, just for information, actually for us, every year the inflation for drug price is about 2-digit increase. So traditionally, other kind of medication and all that is only about 4%. So this is the current problem right now we're facing.
Yeah, and tell me, Mark, how do you respond? I mean, Majda, sort of threw a challenge out there to get clinicians as prescribers for supportive care or survivorship. I mean, what's your reaction to that from, say, a Singapore perspective?
Right. So, okay, so you see, when we request, because some of you did mention about like at a hospital level, right? So of us healthcare professional, everybody knows that we should be holistic in the way we provide the care, because everybody understood there's impact, right? And long-term survivorship, return to work, and all this. But it's just that the structure of many of our healthcare system doesn't allow that kind of conversation, because this kind of conversation does require, number one, you need a lot of time, right? And then the other thing is that many of us are divided based on specialty. So for example, if you're a dietitian, then you can only be like qualified to talk about diets related things, right? So this sort of issues requires you to be what we call transdisciplinary, in the sense where you do need people to know a little bit of something. You get what I'm trying to say? So if everybody knows a little bit of something, right? I don't need to be a dietitian, but I know something a little bit about, like some people answer some question pertaining to patient that have some query about nutrition and all that. If basic things I can answer, I help the person to feel less confused, because I just need to go to one person at least, right? Then that knows a little bit of exercise, knows a bit about the system, right? So which is a deviation from the traditional healthcare system, which we are specialists in that particular area. You get what I'm trying to say? So this is where we are trying to, like, it's a relearning. So it's like now people start to value generalists better, right? And then only if we can't deal with it at the general level, and then you refer to the specialist.
Okay.
Yeah.
All right. So, I mean, I think that's a good explanation of how that might be approached in Singapore. Diane, I'm particularly interested about your views on, clinicians as practitioners and prescribers for supportive care. Like in Rwanda, how would you go about that?
Yeah, I think I really like to buy that idea. But if I would echo what Mark has said, I think there's also a gap in understanding what is supportive care itself by these clinicians. Do they know what supportive care means? And then another thing, there's need to understand what are these needs in our African context, or even in Rwanda itself. So I think if we understood those two, then we'll come up with ideas or adapt ideas from other colleagues on how to best help these patients. So I really think, yes, they're the first people to do that, but also they need to be knowledgeable in this particular area and the impact of supportive care to our patients.
Yeah. And do you think there's been sufficient, because you mentioned understanding a couple of times then, so do you think there needs to be like more research or more education for health systems and health practices in Rwanda? Is that what you think might be a priority?
Absolutely.
Okay. So if you were to think about how the global community could help, and I can see the chat box is on fire with questions and observations, Alessandra. I'm not sure how we're going to deal with that, but I'll talk to you in a minute. But I think there's lots of suggestions. So how could people help in Rwanda, for example? How could people help you?
Yeah, so first thing they should, I think they should come and help us with research. That's the first thing I would say. So research in this particular field. And then we understand best in our Rwandan culture, in our Rwandan perspective, how is this supportive care needs and how can we best help? And I think some of the solutions come from our people in Rwanda, together with other people who are there to give us hints on, their journey, how they started and where they are at. Then two, capacity building, we have several experts in this field, so they could also come and, be an eye opener to fellow colleagues there, me also involved, yeah.
Well, thank you for that. And I know there's lots of people interested in doing just those things, Diane, and I can just see something appear in the chat box here about great points and some support for that. So I'm sure that there'll be people on this webinar this evening or virtual dialogue who'll be interested in connecting with you on that. We're going to have to need to wrap up this session soon, this panel session. So just a single take-home message from each of you, and perhaps, Majda, if I start with you first, perhaps do you have a single take-home message for or a single observation you'd like to share with other civil society organizations out there about survivorship and supportive care?
I would say that even if we don't have the real tools to evaluate impact and efficiency, we in our level we observe everyday great and impressive progress with patients. It's really impressive, and just after a few sessions of supportive care. So I would really recommend to give access to the maximum of cancer patients in our other cities and in all the other countries.
Yeah, just do whatever you can because it can make a difference, I think is the message, and that's so true. Mark, how about from your perspective?
All right. So because our audience are very diverse, so all of us will be at a different stage of the development, right, in terms of your work. So I guess in terms of supportive care, because there's so many things that you can look at, and I mean the problem will be too much to manage. I think it's just really to look at one area that you feel they can do very well in, and you narrow in to do that part of the work. And then once you're confident, and then you can expand to other kinds of like areas of supportive care, you think that you can contribute better. But it's always, you have to start from somewhere, because that's where we started off earlier. Yeah.
That's right. Start somewhere. And Diane, last word on the panel to you. What are your take-home messages for all of us listening?
I think my take-home message really is the topic of today. Let's emphasize on personal-centered care than disease-centered care. To me, that's the message, because if we are really into person-centered care, I think that's when we're going to understand the whole concept of supportive care and go with our patients' journey throughout since their diagnosis. Yeah, that's all I could say right now.
Excellent. And I think that's a message that Chris left us too, wasn't it, about patient-centered care rather than, sort of hospital-centered care or disease-centered care. So, I mean, that's certainly a recurrent theme. Can I ask everyone out there again to do me a favor and find the little clapping hands device for our panel members? I mean, they've done a terrific job. I don't want to single anyone out, but poor Majda's been dealing with IT problems, and I think she did a great job. So to our panel members, thank you, each and every one of you, for those insights and observations. I can tell from the chat box that you've generated a great deal of interest and conversation. And it's also clear from the chat box, when I've been able to see what's coming through, there's quite a bit going on out there. Different models, different approaches, different countries. And Alessandro, I can see your face on my screen, but I think it's a nice thing for us to try and capture that, because we're not going to be able to talk about all those today. but I think if we can capture what has come through in the chat box and share that as a part of the session, that would be terrific. And there was one chat that did come through about UICC role and perhaps spearheading or certainly trying to take a lead in capacity building and in education and in encouraging research. And I know that, you know, Alessandro and Kirsty and the team will be thinking about just how they can do that. So I think there have been lots come out of that. Thanks again to our panel members. And what we might do now is move to the third part of our session this afternoon, which is in conversation with an eminent clinician who's just about to come on screen. I am smiling because this eminent clinician is someone I've worked with for many, many years and a friend. But just because she's a friend of mine doesn't diminish any way her eminence. I assure you of that. She remains eminent despite her poor choice in friends. But it's Professor Bogda Kozwara. Bogda's from Adelaide. She's you know, a world-renowned researcher in a whole range of things. She's a clinical oncologist by profession, but she has made survivorship a crusade for herself personally. I'm going to put it that way. I mean, it's been at the heart of her practice and her being for many years now, and it's just terrific to have Bogda with us. Hello, Bogda. I'll stop talking for a minute now. How are you doing?
Thank you, Jeff. It's lovely talking with you as always. Thank you for having me.
Bogda, we've according to the program, we were meant to have 20, but now we've got 10 minutes. Maybe we can. You know,
I'll talk fast.
Maybe we can hedge a little. Bogda, can I first up? What about for you? You know, an oncologist, a clinician, the notion of clinicians as prescribers for survivorship and supportive care. How does that resonate with you?
Look, obviously, I'm a medical oncologist, so I'm one of those terrible people who is meant to just give anti-cancer treatment and ignore everything else. But I'm old school and I'm interested in people who I see in my room. And people have more to them than just their cancer. So if you identify your goals that include more than shrinkage of cancer, you will identify that people that you're treating have priorities, objectives, they have families, they have school graduations to go to, they have work to attend, they have creative pursuits that they want to fulfill. And that means that my role is to assist them in getting to those pursuits, whatever they might be. So the prescription of interventions is actually one part of the story. I think the first step is seeing the person, and I think Chris actually spoke to that beautifully at the beginning, that you see the person, as opposed to somebody who carries cancer. And if you do see them as a person, your goals of supportive care come naturally into it, and they're part of the care that you deliver.
So Bogda, how widespread do you think, you know, those sort of views you've just spoken about, which are terrific? So how widespread are those views within that broader health system, within the clinical community, but also that health system community, you know, the policymakers, the bureaucrats?
Look, depends who you ask. If you ask patients, I think that there is no debate there. If you ask policymakers and health system planners, it's a little bit different. And I think Mark gave a very good example that drug costs seems to be high on the agenda, certainly very similar situation in Australia. I think one of the big problems is that throughout the world, we still adopt a very old-fashioned way of looking at healthcare delivery. It is an acute intervention delivered in hospitals. And for cancer, it's even worse. It's an acute intervention delivered in specialized, silos, centered, that deal with cancer only, as if people with cancer had no other health problems to deal with. So I think that if we want to deliver better supportive care and better survivorship care, we actually need to recognize something that is bleedingly obvious, and that is that majority of cancer survivors are not in hospital at a time. They happen to be at home, which means that their care is dependent on, to a significant extent, on what it is that they do for themselves within their communities, And also we need to recognize that the current healthcare system in its siloed, complex, specialized form is very hard to get around and navigate. So navigation support is really important. But final thing is, it's not just that we should improve navigation of a poor system, we should actually make the system easier to navigate.
Well, here. As a recent navigator myself, or navigatee, I can certainly agree with you on that. Let's just take a bit of a change of tack for a minute. Bogdi, you and colleagues recently published a very good paper, I must say, and congratulations on it. A very good paper looking at survivorship in the Indo-Pacific region, and it was geographically limited there. And without going into all the detail, but perhaps I think, can you just summarize that for us, for those listening, and also what for you were the insights that you took away from that work?
Sure. So some few observations. First of all, if we were to look at epidemiology, 40% of cancer survivors around the world reside in the region of Indo-Pacific. So defined as starting from India all the way to Tahiti and everything in between. So it's a huge population. And yet, if you look at the evidence on cancer supportive care and survivorship, majority of the papers do not come from Indo-Pacific, which means that they may not necessarily be relevant to how care is delivered within the region. So I think that there is first obvious gap there. The second thing that we've learned is that there's tremendous expertise and excellence within the region that is often unrecognized. There's a terrific research track record in a number of countries. One of the best cancer care plans around the world actually comes from Thailand. There are services, for example, I would love to see the cancer rehabilitation service that Mark was talking about adopted in Australia. So there are tremendous areas of excellence within the region, terrific capacity building initiatives. So I think there's lots that we can learn from the region and really amplify that work so it's visible to the rest of the world, as opposed to assuming that the flow of information is unidirectional from elsewhere. The next thing is that there are some unique problems that are not just driven by resource limitations. We tend to think that countries that have limited sort of low GDP fare poorly, but there are some very interesting examples of the Pacific islands in particular, where the density of population is such that delivering specialized survivorship care is quite difficult. Example is New Caledonia, where expertise in pediatric cancers is excellent, except that there are not many cases of pediatric cancers. So for specialized treatment, those patients tend to go to Australia, which worked very well pre-COVID, but not so well during the pandemic. So this illustrates that the improving care is not just about throwing more dollars at the system, but actually being clever of how we solve problems. And for example, digital technology might be one way of improving care and developing sort of interventions that are very unique to what is the context of a particular setting. So I think that sort of the key message from the paper, and we can post the link to the paper if you want to read it in more detail, but the key message is that there are some really good examples of excellence. And I think that the future lies in us being creative and sort of responsive to what are the unique needs on the ground if we want to improve care, rather than just being despondent that the resources might be limited.
Yes. Well, I think that's a terrific call to action, isn't it? Really, let's be creative, and just picking up some of the comments from our earlier speakers, just do something. I'm not saying that in a silly way, but let's just be creative, and every bit helps, and let's do what we can. Easy to say. What are the challenges, Bogdan? So, you've seen lots of stuff. I mean, I know you're not the sort of person that becomes despondent. I know that. But tell me, what are the things that you see about survivorship care going on, and what are the things that trouble you in the narrative that you might pick up from time to time?
Perhaps I will start it by kind of looking at what are the opportunities that are unrealized? And it's you could figure out whether that's a sort of a challenge or an opportunity. I think that if we want to convince funders and policymakers to invest in survivorship, we need to demonstrate that it is an area just as worthy of investment as obstetrics care or mental health or something else outside of cancer. So we need to use the same metrics. And for that, we need data. So for example, data on employment is really important because inability to work after cancer reduces the gross national product for a country. So if we were to count it, that potentially you could say, well, that's how much money we lose by not treating mental illness versus that's how much money we lose by not attending to the care of cancer survivors. So I think it's an opportunity, but it's not the opportunity that is well realized yet. We do not collect survivorship data, and that's data on prevalence and burden of morbidities. We collect data on cancer deaths, but survivors are very interested in being alive and being alive well. So it's the well bit that we need to build upon. So I think data is one aspect. The other one is we really need to invest in what survivors can do for themselves. And we tend to kind of talk about it, but not really do much about peer support, advocacy organizations. This is where I think UICC is doing better than others, but making them core business of cancer care as opposed to something that is kind of the second consideration. Again, if we have data that it benefits, then perhaps it's easier to get it across the line. I think that survivorship care needs to be embedded in policies, but for that we need national policy strategies. And I think that this is where comparing experience from different countries is particularly beneficial. It's very nice for those of us in Australia to learn that Thailand beat us up to the Better Cancer Plan. Maybe that will motivate us to develop a cancer plan to match. So I think that if we can present data and compare how things are across different regions, that might motivate our politicians to do the right thing.
Well, we're always looking for motivations for our politicians. And speaking about politicians, I mean, what's your sense? I mean, not just Australia, but what's your sense of the political will in relation to these things now? I mean, do you really, policymakers getting the message about the importance of living well after cancer, not just living longer, but living well after cancer? Is that message getting out there?
I think so. Politicians are human too, and they have themselves faced cancer diagnosis, and so have their loved ones. Many of the very successful initiatives in Australia had occurred on the back of a personal experience of a politician with a cancer history. Today I'm very positive because today we are bringing in policies for tobacco control, which is actually really, really important for cancer survivors. Secondary prevention for cancer survivors is not something that we talk about enough, but we should be. And I think that there is interest in lifestyle interventions and obesity control. So I think, well, certainly in Australia, things are better now than they were a couple of years ago.
When
we
that
had
is
a
true.
different government.
And of course, in Australia, for those that might not know, and Bob has just alluded to, there's been a whole raft of measures on vaping and tobacco control just been announced this last few days, which are very important. And it is, I agree with you, Bogda, it's terrific to see. Bogda, our time's just about up for this part. So, as we've done with other speakers and panelists tonight, I mean, Bogda's last word, if I could call it that, in relation, for those listening to the webinar and part of this, virtual dialogue, what thoughts do you want to leave people with?
As a clinician, I'll give you the oldie but a goodie. The saying is, when in doubt, ask the patient. And that applies to so many things. They usually know what's going on. They usually know what they want. They usually know what it is that they need from you. So I think we need to remember that.
Do you know, Bogda? I don't know if that's copyrighted, but I tell you what, that's a great title for a book or a chapter, let me say. When in doubt.
Hey, I'm looking for ideas, Jeff.
When in doubt, when in doubt, ask the patient, you know what? And that takes us full circle pretty much, because it really speaks back to what Chris was talking about when we started
Totally.
this conversation an hour ago. Bogda, thank you. Look, thank you very much. Can I ask everyone again to hit the reaction button and find the clapping hands or the thumbs up? Good on you. Thank you, Bogda, because I really appreciate you taking the time. Ladies and gentlemen, you know, we've had an hour put aside for this and we've passed the time. Can I just remind everyone that this is being recorded and it will be available. And Alessandro, I'm just looking to find Alessandro on my screen now. Alessandro, there he is. Alessandro will make this available. Alessandro is also collating comments and observations. He's already, I can assure you, he's frightfully efficient. He's already, I know he's already sent out the link to Bogda's paper. So Bogda, you can thank us for increasing your H index, by the way, when that all goes through. I think so. Bogda's paper's been sent out. And of course, if any of you are out there, I know I didn't get a chance to read them all because some were coming too quickly, but if you're out there and you've got observations or ideas or suggestions, please continue to send them through. I think, Alessandro, we're happy to receive those and certainly summarize and, you know, add them to a, you know, potentially a, you know, a resource deck. By way of summary, I think key points raised tonight, or well, tonight for me, sorry, this morning or this afternoon, wherever you are. Focus on the person, focus on the person. Can everyone out there remember to focus on the person and not the cancer? I think that's been made several times. I tell you what's been a recurrent theme is about research and data gaps. You know, we heard that from Diane, and we just, you know, we heard that from Diane in Rwanda, but we also heard it from Bogda, you know, in Australia. And I think let's all remember that, you know, research is important, and let's try and build the data. It helps us understand, it helps us to do a better job about responding to needs, and it also helps us influence policy, and all three are critical. There are centers of excellence out there doing terrific stuff. You know, Mark, thank you for sharing that. Majda, thank you for sharing what you're doing in Morocco. Thailand, thank you for having such a good national cancer control plan. I mean, these sorts of things are out there. There are centers of excellence, people doing really good work. So let's recognize those and let's understand those and build from those. Adapt as necessary. That would be important. Bogda made a terrific point. It's not just about money. You know, we can sometimes say, oh, well, we need resources. We need this, we need that to do anything. But, you know, there are ways. And this is, again, where we can look for centers of excellence, where people and organizations and systems have managed to do stuff without relying too much on additional resourcing, but being creative or innovative. And perhaps, you know, that's a priority for us. And of course, you know, finally and always, it's about collaborate. You know, it's come up today. It comes up every time. Learn from each other, share stuff, work together. Where we've got resources, let's make sure people know about it. Where we've got a center of excellence, let's make sure people know about it. Share what we can. So, ladies and gentlemen, on that basis, what I'm going to do is wrap this up. Again, can I thank the team at the UICC? Alessandro, I'm not sure everyone's seen you. Can you just put yourself on the screen, Alessandro? There he is. Alessandro has been driving the ship and doing a great job on this virtual dialogue from Geneva, and you know, a terrific fellow with a heart full of great warmth and compassion for this topic. So thank you, Alessandro, for helping that, and with the team, of course, in Geneva and the UICC. Can I also thank our sponsors? I'm hoping there's someone from our sponsor out there for this session. You know, La Roche-Posay, thank you. We can't do it without sponsors.
Hello, thank you. Thank you, Jeff.
There you are, Benjamin. Well done.
No, thank you. Thank you so much. It's the magic of UICC to be able to gather so many people around the globe to have all these views on one topic. It's absolutely fantastic. Thank you so much.
Well, it is. And again, from the UICC and each and every one of us on this dialogue, and for the many more hundreds that are going to watch it over time, we thank you, and we thank your company. It's important to us, and we do acknowledge that. And of course, importantly, thank you to each and every one of you. So I can't exactly see how many we've got online on this dialogue, but there's a lot. It's multiple screens here. I can't see you all, but you know, each of us is just the beginning. You know, each of us have got connections and systems and individual clinicians and patients we can influence and work with. So take this as an opportunity to push this, to acknowledge that, you know, when you're diagnosed with cancer, of course you want a cure and of course you want to live longer, but it's important to us to make sure that as far as we can, make sure that people live longer, but also live well. And I'll leave you with one of the quotes of the night. If ever you're in doubt, as we've been told by Professor Koswara, ask the patient, because they're the best compass we've got, and they'll point you in the right direction. Again, you know, thank you to Chris, Diane, Majda, and Mark, and of course Bogda, who we spoke to at the end, and to each and every one of you. And farewell for now, and we'll see you next time with best wishes. Thank you.
Thank you, everybody. Goodbye.
Bye.
Bye-bye.